Hi, everybody. Thank you for joining us today for our Learning Network session called Building Capacity in the Behavioral Health Workforce. This is a session I've been particularly excited about because I've been working in the area of healthcare workforce for many years. And I think it's really just critical that as we think about what we can do to promote resilience and healing, we know that the behavioral health workforce can play a critical role in helping people in their healing journey. Among many others, as we all know, having positive relationships and experiences are also critical, but that workforce is an essential element. And I think we all know that recently healthcare workforce recruitment and retention has been a challenge, particularly since the pandemic began. And there are a lot of ways that states and communities are trying to be creative to address these issues. And so today we are going to talk about what some of those challenges are, as well as what some of the solutions might be. For those of you who are new to Pathways to Resilience, we host learning network sessions for the public, with our focus primarily on states and counties and communities to really talk about strategies to address trauma and resilience, looking across sectors and looking across professional fields. Today, we have three fantastic speakers, and I'm going to let each of them introduce themselves as they are speaking, because I can't do them quite the justice that they will do themselves. But we really encourage active participation in the chat. You're also welcome to take yourself off mute to ask questions, but we received many questions in advance that we've incorporated into the discussion today, but really want you to also ask questions as we're going. So I am going to start with a question that is going to be for Hannah. So Hannah, if you don't mind introducing yourself when you start your response. So tell us a little bit about what we know about what's contributing to the challenges of recruiting and retaining the behavioral health workforce.
Thanks so much, Lauren, and welcome everyone to the discussion today. My name is Hannah Maxey. I'm an associate professor at Indiana University, where I also serve as the director of the Bowen Center for Health Workforce Research and Policy. In that role, I work very closely with the state of Indiana and provide strategic and expert support on health workforce matters to the state and to stakeholders statewide. I also do national consulting through Veritas Health Solutions. So I'm very excited to be here with you today and happy to field the first question on, what's contributing to challenges with recruiting and retaining the behavioral health workforce. I think there are a number of things. First of all, behavioral health workforce shortages are not new. We've been grappling with them as a nation, and all of our states and our communities have been dealing with shortages. I think that some of the issues stem from that students have lots of opportunities for what they go into these days. When we look at other health occupations like nursing, students that get an associate degree or a bachelor's degree in nursing, almost all of them want to go out and become nurses, registered nurses working in healthcare. In the behavioral health space, students have lots of different choices and opportunities. For example, social work. Students can get a social work license or a social work degree and either pursue a pathway to licensure, or they can pursue completely different employment and career opportunities that aren't in the behavioral or mental health space. I think that what may be contributing to some of our students not choosing to pursue those clinical pathways are unfortunately wages in the sector. We know based on BLS reporting that the latest reported data, our mental health counselors are making it just under $24 an hour on average nationwide. Many of these roles require licenses at the state level, and many of them require master's degrees with additional post-degree experience requirements. So there's a misalignment between the training and the credentialing and the wage. Just to put this in perspective, if you go on and you look at the BLS and you look for delivery drivers, we all see Amazon and all of the drivers coming down our streets, and you look for the average wage among those workers, you're looking at just under $19 an hour. And the only requirements generally are a high school diploma. So I think students are choosing the pathways that they go into, and wage is definitely a factor for those. There are lots of opportunities. Mission-oriented folks are going to go in and still pursue and work in the behavioral health field. I think that what we need to think about with retention is once we get someone into our behavioral health workforce, providing behavioral health care to our residents, the moment that they're brought in, retention starts then. And unfortunately, we do know that there is high turnover, especially in our community-based settings, where our behavioral health professionals may start out in our community-based behavioral health settings and then leave those community settings to go into private practice where they can make higher wage, or quite frankly, turnover that we're losing to other sectors in healthcare or outside. So those are just a few of the thoughts on the challenges. I'll hand it back over to you, Lauren.
Thanks, Hannah. And Jeff, I wanted to hear a little bit more about your thoughts on this after you introduce yourself, but also acknowledging Adam in the chat is starting to talk about some of the working conditions and organizational climate, which we also know can serve as a challenge. So if you also want to address that.
Yeah, absolutely. So hi, everyone. My name is Jeff Shumway. I'm the director of the Office of Professional Licensure Review in the Department of Commerce in the state of Utah. I have a strange job. I look at occupational licensing across everything. So not just behavioral health, not just healthcare, but literally everything. This last year, we've spent looking at behavioral health. And so I've gone really deep into that and learned a lot from people like Dr. Maxey and Libby Abbott and others. But I'm not an expert and I'm not a licensee. So everything I say should be taken as a smart layperson who got his hands on some data. So in that spirit, I'll just say two things. One, responding to what was said in the chat. Anecdotally, we surveyed every single behavioral health licensee in the state. We spoke with about 500 of them in focus groups and other meetings. And I think what you're getting at, we found to be true, at least anecdotally, that supervision and the quality of supervision and the amount of time you spend with your supervisor is actually a big reason why people will burn out quickly or why they'll stay. And so the quality of supervision, I believe, is actually part of retention. It's not just about safety and gaining people's skills. It's actually about retention as well, because these occupations are difficult. They take an emotional toll, and especially if you don't feel mastery over what you're doing, I think that can lead to burnout and turnover. The other thing I wanted to add here, I love that Dr. Maxey went to student choice. We actually ran some analysis here in Utah with our partners in the Utah system of higher ed, who tracks, everyone going through their system. They graduated almost 6,000 psychology majors over the last 5 years. They graduated 1,500 social work undergrads over the last 5 years. One of those can get a license and participate in behavioral health. The social workers, psychology majors cannot. There is no license in the state of Utah that will allow you to then be licensed and participate in behavioral health. So I think there's a bit of a bait and switch with a lot of undergraduate training. We found multiple majors where people probably have some interest in behavioral health, but it doesn't lead to licensure, and they don't know that going in. And so I think there is some work to be done there. The last thing I'll say is there's also just a general gap, and I'm going to share some data here if I can find the right thing. There we go. As we looked at all of our licensees, if you look at the medical workforce, the licensees are this nice pyramid where 2/3 are bachelor's and under, and they act as paraprofessionals, extenders. These are the nurses, and they extend the expertise of those with advanced degrees. So these are the nurse practitioners, the PAs, and of course the doctors. Behavioral health is exactly inverted. In fact, even more so. It's skewed towards those with a master's and above, and there are very few extenders. And I think in many ways, when we talk about the problem in recruiting and retaining, it's because there's this massive educational gap, licensing gap, reimbursement gap for the lower part of this pyramid. What we found is you can get a 1-week training course in Utah and become a peer support specialist. And I think this is true for a lot of the nation. From there, you really have to go on and get a bachelor's and a master's and do 2 years of supervision before you can really participate in the workforce. So we just have this massive gap and people can't move up, especially working adults. So I think that's a massive part of kind of the workforce misalignment that we're seeing.
Thanks so much, Jeff. I'm going to move on to another question. So I want to talk a little bit about the strategies we can use to systematically analyze shortages and gaps in our states and communities. I know, Hannah, this is something you do a lot for the state of Indiana, and that you've supported a lot of other states in this work. And then I'd love to, Libby, have you introduce yourself and share what you're doing in California. So Hannah.
Sure, happy to take that, Lauren. So there are many ways that states and communities can identify whether they have shortage. The first, I think probably many of us are familiar with this, but the federal government does have a designation process for communities to be federally designated or identified as mental health professional shortage areas. Every state in the nation has an office that works with the federal government on identifying their shortage areas. For mental health, these are mental health professional shortage areas, or MHPSAs. If you hear that word, that's what it means. So a first step for states or for communities or advocates or stakeholders, if they want to know what are their shortage areas, they can go to their mental health HPSA list, those federally designated communities. Those may or may not show a state or a group or a community all of the information they need about shortages. And a critical piece of identifying those shortages is having workforce data that can help states identify not just how many people in their state hold a license in a behavioral health occupation, but how many are actually practicing and providing care to the residents of their state. Where are they practicing and providing care? Like the specific community that they're located in. Are they providing telehealth services? And really importantly, what types of populations are they providing care to, and what types of care are they providing? Is it mental health counseling generally? Is it substance use disorders? So that type of information is very important for states and communities to identify their workforce capacity and understand where they have shortages or gaps that need to be addressed. Those questions might seem simple to answer. They're absolutely not simple to answer. Many states have been implementing a strategy to collect workforce information on their healthcare workforce, including behavioral health professionals. And that strategy is to basically gather that information when they're licensed health professionals, like behavioral health counselors, when they renew their license. In most states, that's every 2 years. There are a few states where it's every year or every 3 years, but it's a routine cycle where state regulators have the opportunity to collect that really important information to help identify what workforce capacity actually looks like and where there are gaps or opportunities to strengthen the workforce. So there's new tools now to help states that are interested in collecting that data, specifically an organization called the Healthcare Regulatory Research Institute. I know that's a mouthful, but they recently worked with 7 National Healthcare Regulatory Association boards. So the National Council of State Boards of Nursing, the Federation of State Boards of Medicine, and several other national organizations to create a consensus cross-professional set of questions that states can ask when their health professionals and behavioral health professionals renew their licenses that will help that state answer those critically important questions. I'll make sure I drop this resource in the chat, but that is definitely one key way that states can gather that information and ensure that their communities and partners have access to the information they need.
Thanks, Hannah. And I just want to put a finer point on that. And, if you don't know, for instance, like somebody could be licensed in Arizona and Colorado, but really live in Arizona and only practice in Arizona. Somebody could practice, but not accept Medicaid. So to really understand fully where people are practicing and who they're serving, there's just this little bit of information that if it's collected every time at licensure, it's helpful information. And I see we do have some questions that are coming in the field. Adam is asking, I think he's asking what you, Hannah, were you saying the Healthcare Regulatory Research Association? Is that what you were saying?
I'm going to drop it in the chat. It's the Healthcare Regulatory Research Institute. So I'm dropping the link in for everyone right now so that you have access to that. This website will take you, it takes you to a web page that actually has that set of questions, as well as all sorts of resources and additional information that can help states or regulatory boards or state departments of health identify if this type of workforce information is key for their state and what would the next step be to collecting it. And thank you, Lauren, for adding that additional context. This data can be useful for a myriad of initiatives. State Medicaid offices need access to this to understand, what the networks look like or where they can do provider recruitment. There's a myriad of uses outside of just behavioral health workforce assessments.
So Libby, I'd love to, we're going to provide a couple more links too. There's a report Hannah and I wrote a few years ago for the National Governors Association and some other tools. But Libby, share with us a little bit about your strategies in California.
Absolutely. And good afternoon, good evening to all those who are joining. Great to be here. I'm Libby Abbott, the Deputy Director for the Office of Health Workforce Development in California's Department of Healthcare Access and Information. We're a very data-focused department, so I love this question and I love following Hannah's initial response. All stuff that we're thinking about and doing in the state of California. I want to talk about two things. So I think there's two ways to sort of talk about how we address behavioral health workforce shortages. We can do that in the present, and we can do that thinking about the future. So in the present, I just want to say quickly that Hannah talked a little bit about mental health shortage areas and MHSAs. This is a type of health profession shortage area that's a really great tool for us. And at HCI, we use these shortage area designations to score applicants and to allocate funding, because our goal is to reduce shortages and expand access to care. So this is a really useful sort of data-driven way for us to do that. One of the challenges or constraints of the mental health shortage area is that it's limited to mental health. So when we talk about behavioral health, we're talking about a much broader range of services. And certainly in California, it's kind of the other components that are placing increasing pressure on our systems. And in most cases, the way that a mental health shortage area is measured and defined, the provider they're looking at is a psychiatrist. So that is one sort of measure of provider availability, but we're interested in going beyond that to understand what a behavioral health shortage area might look like. So just highlighting, this is something that's very new and nascent for us in California, an idea we're going to start building out over the next couple of months, but we're looking to propose what we think might be the first in the nation, and certainly the first time in California, a behavioral health shortage area definition and designation. And we're going to try to take a more comprehensive look at the types of providers, kind of from the base of that pyramid that Jeff showed us, all the way up to the top, find the appropriate mix and use that to better understand what our behavioral health shortages look like in the present. Looking forward, so the kind of future-facing question of what are our future behavioral health workforce challenges, I think is equally important, because we have a crisis now, and we know that it takes years to train health professionals. It takes years to change the composition of your health workforce or to get them to the places where you want them to serve. So we really have to be looking ahead to where we want to land and implementing those activities now. So we're launching in California at HCI, the Department of Healthcare Access and Information, a behavioral health workforce strategy process. And that strategy is going to start with and be anchored in supply and demand modeling. So the first question we're asking is, what does our behavioral health workforce need to look like in 10 years? How will service delivery in behavioral health change? I think there's a lot going on in the space that we need to be thinking about, the expansion of crisis lines and new types of services, meeting people in their communities and out where they're living. So we need to think about what that service delivery change will do to workforce requirements alongside population growth and changing dynamics. We'll use that to map then what we think our workforce needs to look like in, let's say, 10 years. What types of providers do we need and where will they need to be? I think that will be an interesting and complex set of questions, because particularly in behavioral health, we have a lot of overlapping scopes of practice and a really wide number of types of providers who can provide those services. Once we do that, we'll cross that with our forecasted supply. So based on where we are now with training capacity, How many do we think we'll have in 10 years? And then we look at that gap for each type of provider and at the sub-state level geographic region. And we'll use that to determine where we put our effort and our dollars. Do we need to scale training? Do we need to focus on retention? Is it a combination of the two? What are the levers that we need to pull to get our supply line to match our demand line? So something we're very excited about. We should have the results of that at the end of the year, and then we'll really be using that to dictate how we prioritize our resources.
Fantastic. And I see a lot of really wonderful questions coming up in the chat. Some of them we're going to get to. We're going to be talking about non-licensed professionals and other staff extenders shortly. I do see there's a question in here about the with regard to health plans. I'm trying to find it. I lost it in the chat, but I think from Kenneth Epstein asking about reimbursement and payers and the role of payers in this gap, in particular reimbursement. We reimburse what we recognize as critical. Can we discuss the role of healthcare reimbursement in maintaining a shortage? I don't know if anyone feels comfortable taking a stab at this question. Anyone? Well, I can say in some cases I have seen in states they will have a requirement in contracts with managed care plans or such that they use certain types of professionals. I've certainly seen that happen in the past. So sometimes the state is pulling a lever for that they have for that decision making. But obviously, like, reimbursement levels will matter with health plans. So if anyone else wants to chime in, feel free to do so. But in the meantime, while you're thinking about that, I'm going to move on to another question, which is how, as we think about facilitating change at the organizational level with leadership, especially in an era of limited resources, like, what can we do? Like, how can we facilitate some of this change? It was a question that we got from a registrant.
So I'm happy to take this, and as a state health workforce policy researcher, I'm going to take a state lens at this, and I really appreciate the work that Libby is helping to champion in California. And I want to piggyback on that from the vantage point of a state being an organization and her discussion about the pipeline, or, you know, the demand and the supply and where they're getting their supply from. I think it is critically important for states to focus on their workforce and identifying their shortages and getting workforce data. And by the way, identifying shortages in the way they define, right? So I'm really glad Libby brought that up. But it's also really important for states to keep a finger on the pulse of what their training pipeline and pathways look like. And so I'm really glad California is doing that. Actually, in Indiana, we have work underway to do a comprehensive behavioral health training pipeline assessment. It's really important for states to understand, if they don't right now, what are the training, the degree programs, what are the levels, where are they located, how many students are in those training programs and coming out into the pipeline, where are those training programs located? So I do think that planning is a leadership activity, and the prioritizing of assessing that portion of this important discussion is critically important, and it's been overlooked a lot when we have health workforce shortage discussions. And so I personally think that is one very important thing that leadership can prioritize. The second, and I know it's limited resources, but I think that from a state level perspective, there can be an opportunity to investigate how incentives are being aligned to promote recruitment and retention in the workforce. I mean, the question about reimbursement, that is a really tough nut to crack. Okay, so I really appreciate the question and the comment. I wish there was a magic wand that we could wave, but there is a need honestly, for system transformation to truly address the issues that we have going on with payment structures. But workforce incentives, nonetheless, are critically important. And I think states have a unique opportunity to look at what are they doing right now related to incentivizing or developing the workforce, and are those currently allocated and appropriated resources being maximized, right? So leadership can also say, where are we spending our time? Where are we spending our resources? And are there better ways for us to do that to achieve the goal. So those are just some thoughts from the state level leadership perspective.
Thank you. Jeff, anything you'd like to add on this one?
I guess I'll get nerdy again and share one more slide, but I think it bears on this. I'm trying to come at this more from an organizational perspective. If you're working in a big provider network or a nonprofit, one of the things that we found, see if that comes up there. So we surveyed every single licensee in the Utah database using the protocol that Dr. Maxey referred to. We did a little bit of tweaking around the edges, but it was a really strong foundation for us. What we found is of the 16.6 thousand full-time equivalents that we have who are licensed, some of them are not working in behavioral health, some of them are not working primarily in Utah, and then many of them are working part-time. And so we had to sort of discount down until we got to this 11,000 full-time equivalents of actual, people, right? Then you cut out the administrative burden, right? The time not spent with clients, and you get down to 5,500 full-time equivalents of patient care. So I guess from an organizational perspective, what I would say is you may have a certain amount of licensed people you're working with. What you get out of them in terms of patient care, you have some levers there in terms of people who are out there who are licensed but may not be working in behavioral health, or may be working primarily in telehealth or something else. Those that are working part-time that you might be able to entice to do a few more hours, and then trying to minimize burden as much as possible, which again comes back to insurance and payers and the burden that comes in there. So it's not a full answer to the question, but I do think there are these places around the edge where we can optimize and actually get more care to patients with the same workforce we have now. The other place I would point to here is, I think optimizing on scope of practice is actually a really interesting one. So at least within Utah, we found that a lot of folks were reticent to get up to the edge of their scope of practice, which actually leaves a lot on the table. And so having clarity with your, with your attorneys, with your legislature, with your licensing body to understand exactly what the extenders can do, right? The folks that are the crisis management certified folks, or case managers, or peer support specialists, or in our case, we now have some other extenders that we'll talk about, and California does too. Using them to their fullest is actually free lunch, right? Like you can get things done there if you understand their scope of practice completely, that you might not be able to with a constraint on master's level clinicians.
So I saw there was some chat about community health workers I saw before, but I'd like to just shift more broadly in general as we think about some of the kind of behavioral health workforce extenders that might be used to bridge the gap. And so we also have a question that we received about how we've addressed licensure and liability issues for these professions. So I'd like to start with the conversation about extenders and behavioral health with Libby.
Great. And I was just furiously taking screenshots, Jeff, of your slides, so you should send those along later. This is a really great conversation. And I think it segues nicely from what Jeff was speaking about supporting folks to practice at the top of their license or at the top of their scope of practice. So in California, we're in the process of unveiling a new type of provider, a certified wellness coach. We're very much midstream on that launch. We, in 2 days, will launch certification for our first wellness coaches in the state. And this is an excellent example of an extender type of provider. So these are folks who have a associate's or bachelor's degree and who are doing predominantly preventive, promotive, and referral services. And our hypothesis and our expectation is that if we're getting these wellness coaches out into schools and into the communities where our youth are, so this type of provider is really targeted at youth behavioral health. If we're getting them out into the settings where our youth are, then we're allowing them to provide the really essential preventive, promotive, referral components, which frees up our very limited school counselors and youth therapists to practice at the top of their license and to do the kind of more advanced care and clinical care. So it's a really excellent example of everything that's just been discussed. In terms of liability, I mean, I think we're very clear here that the wellness coaches are certified. They're not licensed. We have put a lot of thought into what the minimum curriculum is, what the minimum certification requirements are, what the minimum field hours are to make sure we have folks who are really adequately prepared and trained to do the work. And are pretty confident that we're not going to run into major quality issues at scale.
Thanks, Libby. Jeff, can you talk a little bit about the work that you're doing to ensure that there's high quality and not challenges or issues with relation to licensure and liability?
Yeah, so licensure is my life right now. I love it. It's all that I do. I will say that we started down this path of trying to figure out the extenders. So because of that inverted pyramid, we were thinking about how can we make better use of folks with a 4-year degree that's not just social work, because social work was the only bachelor's level license that we had in Utah. And so we actually proposed something very similar to what Libby was talking about. And we only later found out that California was doing something similar. So we have a behavioral health coach, which is a bachelor's level, and that takes anyone with a 4-year degree in a related major and lets them take a few additional courses, gain experience in behavioral health in an unlicensed role, and then become licensed. And they can do, we're actually pushing the boundaries a little bit. They can do all the things that Libby was talking about, but we also have them, we proposed that they would also be able to do manualized evidence-based therapeutic interventions in some cases when as directed by a clinician and under a treatment plan written by a clinician. And then we also have a 1-year certificate. So similar to the associate's level that Libby was talking about, we have a 1-year academic certificate that would lead you to a behavioral health technician certification. And that's being offered at 4 public higher ed campuses in Utah. And so we're hoping to really fill in that gap so you could become a peer support specialist, move up to the 1-year technician, and then actually through a little bit more training with an associate's and experience, you can actually get the behavioral health coach license in our proposal. And by the way, I keep saying proposal because it's going through the legislative session right now. It passed the Senate this morning. We have our fingers crossed that it will make it through the House and be signed. In terms of quality, we've actually had to do quite a bit of work on quality. So Utah is in this interesting place where we're one of those states down the middle of the Rockies that has fairly poor behavioral health outcomes. So high suicide rate, high suicide attempts, and there's a whole set of states down the Rockies that have this. At the same time, we found that we had a fair amount of safety concerns. So the number of adverse actions taken against Utah practitioners is higher than the median in the National Practitioner Data Bank. And so we're trying to tighten up supervision quality. At the same time, we're trying to get more access and get more providers through licensure. And so we've had to be fairly nuanced about how to do that. So the extenders are one way. The other way is we're trying to open up access while still tightening quality. As we're proposing to create a master addiction counselor license. So the folks moving in from other states who have that education and license could do that. And then we've also proposed prescribing psychologists, which is happening in the Department of Defense and 6 other states, which would open up more behavioral health prescribers. So all that to say, it's a massive undertaking. I've left some links that I think Lizzie can drop in the chat for our full report and recommendations, and you can see what we've done on this topic.
Thanks, Jeff. I'm seeing some questions come in about the connection between the workforce and trauma and vicarious trauma. I'm including a link to a paper that we wrote recently, a few years ago, actually, for NASHP, the National Academy for State Health Policy. It's more broad. It's about primary care workforce and nurses. But I think a lot of the points in here are really relevant because some of the same things started happening, particularly during the pandemic. And we found that there were things happening like physician health programs, PHPs. They can really help physicians who are at risk of impairment and provide an alternative to disciplinary action. Also, the states have the authority to remove physicians' obligations to report participation in PHPs to licensing boards. So the bottom line here is that if people have some of their own challenges going on, that they don't have to worry about seeking support and help and treatment and think that their jobs might be threatened. And those are really important. Similarly, wellness programs can provide counseling or peer coaching. Virginia is an example of this. They have the Safe Haven program that was established in 2020. There also, Hannah talked a little bit about licensure questions, and what can be added. It's also important to think about what not to include. So there's opportunities to limit licensure questions about diagnoses and treatment to only those that are really absolutely necessary for safety, because that can limit the barrier to seeking treatment and ease physician or other provider concerns about their license being suspended or revoked. And so I think those are some specific examples for people who are wanting help, wanting to get treatment, and are fearful. So those are some ideas, and it's not really just applicable to physicians, but some of the strategies that we identified are specific there. There's also preventing burnout by addressing staffing levels and administrative functions. We certainly saw during the pandemic in particular, there was a really high rate of traveling nurses coming in, and there was a lot of issues just with the rates and what was happening to the workforce there. And I think making sure that you have the appropriate staffing levels can be really important. Having hospital staffing committees to help with those staffing plans, having mandated nurse to patient ratios can be helpful. And having that public disclosure of nurse staffing levels too can add that transparency and accountability. And then there are just sort of other things like streamlining electronic health records. There's a lot of administrative burden that happens too with the work and the amount of time that people are spending. So those are just a handful of the strategies that we identified. There's also violence prevention programs, protecting names and provider confidentiality. We were hearing a lot during the pandemic about providers being attacked, or people threatening them, and then also having penalties for assaults or threats against providers. So again, these were really prevalent during the height of the pandemic, but they're always things that we have to think about and be concerned about. And I think in general, not just for healthcare providers or behavioral health providers, we need to be thinking about how we're creating more trauma responsive workplaces. And this is something that we do trainings on if anyone is interested, but we do work around thinking about what it means to be a trauma responsive organization and how you can effectively support your workforce so that they do come back and that they do stay engaged. So I do want to pause for just a moment to see if anyone has any questions they want to ask out loud. We also have the chat, but I did want to. All right, we'll keep going, but I do want to encourage you. We're seeing some great questions in the chat in general.
I can share a question. I was just typing this long chat message and I couldn't figure out how, maybe it's easier to say out loud. I think so many people struggle with advancing in behavioral health because they can't afford to stop working in order to go to school or to get postmaster's licensure. And I think the more the schools can support it and the more workplaces can support it, makes a big difference, because that's the biggest barrier is somebody can't afford to go, like if their job could count as the training, which many times it can, that makes a huge difference.
Go ahead, Hannah.
I'm happy to speak to that. So thank you for raising that. I think cost of training is a significant barrier. So if I did not say that earlier, I'm sorry. It is a significant challenge to recruiting people into these fields and through the pathways. I think what you're suggesting is on point. Training partnerships are critically important, and those could look like a myriad of things. It could look like individuals in more entry-level positions working in community behavioral health roles that are employed by organizations that allow them to go part-time while maintaining benefits and pursuing more advanced training. There can be students that are engaged in training programs or in academic degree programs. It may look like training partnerships that actually provide paid internships. I know across the states, there are numerous reporting of challenges in identifying preceptors to serve as the supervisor during that postgraduate period on your way to full licensure. In some cases, I've heard reported that these new graduates are paying people out of pocket for their supervision. that would be akin to a medical resident paying to go to their residency. We wouldn't
Nope,
accept
that happens in my system sometimes too, is they can't, because my system isn't supportive always of someone getting supervised on the job, even though we can technically do it, people have had to go outside and pay a supervisor. So yeah, that kind of thing does happen. So, and there's ways to be creative, I think.
Yeah, and I think that those ways to be creative, states can have a role in that with looking at workforce investments and training investments. But then I think employers also need to be a very big part of that solution, and see contributions and putting resources toward this as part of their workforce development strategy. So thank you so much for raising that. It's a really important issue.
Thank you. Thank you so much.
Yeah, and if I could just jump in here actually and share a little bit from the state of California. So that's definitely something we're thinking about. You said earlier, Hannah, the cost of training is prohibitive. And I think for a long time, we've been focused on the cost of the training program itself. So we've been supporting scholarships and loan repayment programs. What we're not addressing is what is the cost to the individual to then pursue their clinical hours, as you described. So something that we're hoping to do more of going forward, and I think other states and entities can explore, are apprenticeships, transition to practice programs, paid internships, as you described. And actually, there was a question earlier about leadership that, a thought that I had was that it's also about kind of intersectoral or cross-sectoral collaboration and leadership. So part of how we're hoping to address this challenge is through greater collaboration with our labor and workforce development agency. They actually have a stronger history of dealing with apprenticeships and similar types of programs. So we have some things that we can learn from them and ways that we can collaborate to address sort of that paid and supported transition to practice in the healthcare space.
One thing that we've proposed in Utah, and again, may become law here soon, is along these lines, is an alternative pathway which does not require passing a national standardized exam, which is fairly radical. But I think if many of you have been paying attention to this debate, especially within social work, the national exam seemed to be very linguistically and culturally mediated, I'll say, such that it was preventing some folks that people felt were safe from becoming fully licensed. So especially in a state like Utah that has a lot of frontier counties, and I'm thinking of San Juan County, which is largely indigenous, we have a strong Latino population. We were finding a whole lot of folks caught at sort of the associate license level and couldn't move through. And so we're proposing and considering now a pathway where you show that you attempted the exam once and then you do additional clinical hours in lieu of that. And what's interesting about that is the research shows a strong correlation between doing supervised clinical hours and building skills and patient outcomes and patient safety. It shows almost no connection when it comes to the standardized exam, right? We couldn't find studies that showed any change in skills, behaviors, patient outcomes, patient safety related to the national exam. I think that's not because they're bad exams, but largely because they are duplicating what the master's is doing in terms of abstract knowledge. So that's another way to kind of open up at very low cost to the state anyway, additional workforce that's not fully licensed right now. And those then can go on and become preceptors, supervisors on their own once fully supervised.
Thanks, Jeff. Liz, I saw you wanted to ask a question.
Yes. So I guess it's related to the same thing. I have a degree, Master's of Education, specializing in rehabilitation counseling. I got it in New York. And one of the things that we had an issue with oftentimes is that our area of specialty is all disabilities, physical disabilities, mental health diagnosis, substance abuse, all. That's where we focus on. That's the basis of the work that we do. And so we found it hard in New York and then across the nation, but in New York, at least, they were more supportive for the consideration first of the master's degree, but also we had national certification. So you could become a certified rehabilitation counselor. And what happens outside of New York, that certification was not respected. And it was even where licensed mental health providers were considered in many other states. and our degree wasn't. Even after 3 years of going to school and getting the certification and doing practicums and doing internships in these fields similar to social work, it just wasn't seen. And we were often told that they were lobbying for social workers that we just don't have, or our field just didn't have. And so many areas or many states didn't realize that we were totally and completely qualified, if not overqualified, especially with disabilities specifically, to do the work that we do. So oftentimes outside of New York, we would have to find other ways we fit in, and kind of convince employers that we're beneficial, but yet still taking less pay, even with the degree, taking less pay than licensed mental health providers in some of the fields, because our certification was not seen as valid in the work. So has that been looked into by anyone, to take something that already exists, a group of professionals that already exist, that they already have national standards and criteria that they meet? Is that something that anybody or any state is looking into?
I think there's a lot of corollaries here. I don't know if anyone has anything specific on your profession, but I know, Hannah, like this is a topic you and I have talked about, where people have very specialized experience, but then other people who might have less training and could be paid less end up with the jobs. I don't know if there's anything you can say about that specifically.
Well, I first of all want to validate you, and I'm so sorry I can't see who asked the question, Liz. I want to validate you. That is very unfortunate, and I'm very sorry that this is your experience. Unfortunately, we have significant variations state to state in the way we define this group of professionals, who we regulate, what degrees we accept. That is a major barrier nationally, and it's a barrier, it's an economic barrier for individuals who can be contributing to this workforce. So I really wish that I had a solution for you. I want to validate that your experience that is a known problem. And
Hannah, one thing I think we could talk about, not to interrupt you, but I know you and Jeff and I have talked about this a lot, like the cross-sector partnerships and how we can better think across academia. What are the degrees that are being offered, what are the certifications being offered, what are the licensure boards thinking, and how we can think across the board so that we're graduating professionals who can then get jobs within their state and elsewhere. So sorry, I didn't mean to steal the thunder of the answer, but I don't know, Jeff and Hannah, maybe you can speak a little bit to that, because Liz, it's not an immediate answer for you, but I think it's a bigger picture strategy that we need to be thinking about.
Jeff, do you want to take it first? Because I've talked a lot.
Sure. I'll take a crack, and then everyone else should correct me. I mean, one of the things that's interesting, I have a Utah-centric point of view, right? But one of the things that I realized as soon as I got into this job and started thinking about licensure is that licensure, in the absence of connection and alignment with higher ed programming and payer reimbursement policies, is kind of pointless. The licensure is a really important, and I would include in that certification, right? You're talking about a private national certification for voc rehab counseling. It provides this really interesting fulcrum where it defines the training necessary and the scope of practice of what you can do. And it doesn't mean anything unless you've got the right educational pathways. So when we started this review of behavioral health, we reached out and worked really closely with the Utah system of higher education, and we're able to align some of those pathways, as I mentioned earlier. So they created new programming just for this behavioral health tech. We're talking about realigning courses so that people can get this new behavioral health coaching license that we talked about. And then we've actually started conversations with Medicaid, with CMS, with commercial insurance here in the state to talk about reimbursing extenders and building out the bottom of that pyramid. So I think, to Hannah's point, that doesn't solve your immediate problem, but I do think that there's been a massive misalignment between higher ed and the workforce generally, and behavioral health is no different. In fact, it might be worse than most, because it has this sort of hodgepodge state to state, a number of different occupations that can fit within the umbrella. And we haven't done a good job of clearly defining career pathways for students making choices, in high school, in undergrad, as they move forward into advanced degrees.
And the only thing I'll add to that is to get then to what your experience was, Liz. It's the interstate translation of that, right? So it's states are working to align their higher education training with their licensure. But if that's done completely outside of looking at the national context or the context of their contiguous states, then that's a challenge for people to be able to take their skill set and go to that next state. And we have experienced some of that, where we create a special license and a special educational pathway for a specific type of behavioral health worker, but then that worker is limited to that scope. And so I think this is a place where there's a lot of opportunity for work to be done and interstate conversations to be had. States have to develop the workforce that they need, but there's also, I think, opportunities to ensure that as they're developing their workforce, they're doing so in a way that doesn't limit people from being able to go outside of their borders and also be able to provide care and services.
And I think at the moment, the onus is on the professional to basically have to ask their university, where are people getting jobs with this degree? Are they getting them outside of the state? And figuring out or asking the associations, this degree, is it being recognized elsewhere? Sorry, Liz, did you have a follow-up there?
Oh, yes. So to add on, I guess not understanding the degree, I guess it might help for me to explain. So there's a program for rehabilitation counseling. I don't know how many states offer it, but I don't know every university, but at the university that I went to, literally to become a school counselor or become a licensed mental health professional, it was 1 or 2 classes that were different. Only 1 or 2 classes. And I had individuals that I other students that I had classes with, that they took those 1 or 2 classes and they were able to get that licensure, and they were able to then translate that into, like, I think somebody moved to South Carolina and they were able to do it. So it was, yes, I agree that that's something that I guess the individual has to take responsibility to know what their program and know what's offered and all those things. I think that's something that surprised a lot of us at the end of it, that those 2 classes, if we just took it, and especially if we had a supervisor that had both the certified rehab counselor and the licensed mental health professional, then we would be able to address the criteria that they have for the practicum and internship, and having that supervisor, we could have been fine. I know personally I had that. I had a supervisor with both. So if I took the additional classes, I would have had it. So it's something that, so I understand that it's every state, but like I said, the 2 classes made the difference. So if it's just, and I have a friend that's trying to go into mental health counseling, but she has to do the internship and practicum over again for that reason. She didn't have it under somebody with that. So what I'm just trying to say is that there's such a small difference that I know that things are, I think somebody was talking about petitioning to the legislature or something like that. I'm sorry if I'm not explaining well, but it's such a small change. I would think that would take less of a push than trying to create something that has not existed before. So that's the only reason why I'm thinking about it. I'm fine where I'm at. I love where I'm at right now. And I'm not really doing rehab counseling, but the skill set still applies to a lot of different areas. So I'm fine. You don't have to look for it for me. But I was just putting it out there because if there's something already there and it can easily address everything, and many states acknowledge the licensed mental health counselor, and it's just those 2 classes, I don't know if it's changed. I would think that would be easier. It's just a suggestion.
Thank you, Liz. I'm going to take one more question here, and then we're going to go to our takeaways. So, Hannah, I'm going to turn this one to you, although others may have answers as well. So we got a question about recruiting people of color and people with lived experience into the work and making the environment supportive of them and their professional mobility. Hannah, I know when we think about nursing, or you had some research you did in this area that was kind of informative. I don't know if you want to speak to that.
Yeah, I can speak to that very quickly. We in the state of Indiana looked at nursing pathways that started at the CNA level. There was discussion about the certified nurse aide as more entry level workforce in healthcare, and there was a perception that actually wasn't part of the intentional pathway to nursing. In the state of Indiana, we did a study where we actually, using workforce data, were able to link records for certified nurse aides and all other health licenses that they subsequently held to identify that, in fact, thousands of individuals in the state started at a CNA, went on to LPN, went on to registered nurse, and even higher types of licenses. But what was most important about that is when we actually looked at those pathways and the characteristics of who took those pathways, we found more than twice the percentage of underrepresented minority populations in that pathway that went from CNA, spent years as a CNA, obtained their LPN, their licensed practical nurse, spent years as a licensed practical nurse, and finally went on to obtain their registered nurse license. That data, that study showed that that was obviously a more accessible pathway potentially for diverse populations. So I would suggest that in the conversations about behavioral health workforce and how do we talk intentionally about opportunities to diversify the workforce, that we look at how we're establishing those pathways in a way to remove cost barriers, to facilitate people who want to move from one step to the next, and make that an intentional pathway. So I think, thank you for raising that. I'll drop that paper in the chat for everyone.
I put it in for you, Hannah. Oh, I direct messaged you on it. Sorry. Yes. If you want to share it with everybody, that'd be fantastic. So we are just now going to do a very quick run around of our speakers to have you each share one or two takeaways of things. If somebody wants to take action, do something, what should they be thinking about? Libby, let's start with you.
Great. And I just actually dropped into the chat something related to what we were just speaking about, which is looking at our data to understand, similarly, if our goals to diversify the workforce, where are our candidates from communities of color starting in nursing. This is where we looked at this specifically, and we saw that they were starting at the associate's degree level. So we shifted our dollars in that direction. So I think just my takeaway that I would double underline, we've all said it a couple of times today, is that having data is so critical and so essential. And I'm really excited to have learned today about the Research Institute. And we're going to take a look at those questions to see if our licensure survey can be tightened up. But it's been a hugely helpful tool for us. Would encourage other states to do the same, and then to think about some of the supply and demand modeling and those evidence-based decisions for how you develop your workforce.
Thanks so much, Libby. Jeff.
I guess I'm going to double down on extenders because you've heard from the two greatest states in the nation, California and Utah, that we're both doing it. So I'm sure Indiana will follow suit soon, and from there to, you know, Ohio and on. But I do think that the extender idea is so powerful because it, by definition, it democratizes entrance into the workforce. It lowers the barrier. It does that for sure. So it provides this diversity into the workforce that I think we're all looking for. It also provides just a pipeline to those who will go on and potentially get a bachelor's and a master's at some point in life. I think there are two other things which are sort of unsaid in the conversation around the extenders, which is, number one, it opens up new potential interventions. So I'm really excited about this idea of manualized, evidence-based, codified interventions that in some cases we're having computers do them already. Having a human also be able to do them with less than a master's, I think is potentially really interesting, and could get us more access at lower costs, and in some cases better outcomes, faster recovery times. There are some studies that show that potentially. And then what was the last piece? Oh, the last piece is we think in some cases they could be reimbursed, right, by CMS, through Medicaid plans, through commercial insurance. So we think it could be a really big move if we can get this to happen in more states and get it really taken up. So I'll end with that.
Thank you. Hannah.
Okay, I'll round us out. Data is so important. You need to keep a finger on the pulse of the workforce. If you are with the state, if you are, with a state partner, if you're with a community, know what data you haven't for your community or your state. Identify where the opportunities are to have better information, whether it's on the workforce capacity or your training pipeline, and then be intentional to turn that data into action, to develop plans and continually evaluate those strategies that you're implementing. So thank you so much for having me join the convo today.
I want to thank all of you, Jeff, Libby, Hannah. I've been wanting to do this session for, well, since we started Pathways to Resilience. So I'm so appreciative of all of your expertise. Thank you, everyone, for being such active participants. I look forward to seeing all the wonderful things that you all continue to do. Thank you for joining today. This will also be posted online within the next couple days. So feel free to send it on to others so that they can watch as well. Thank you, everyone. Have a wonderful afternoon.
Thanks, everyone.
Thanks.